Hello everyone, my name is Adam Amundsen. I'm a regional anesthesiologist from Mayo Clinic in Rochester, Minnesota. Welcome to the 47th Annual Regional Anesthesiology and Acute Pain Medicine meeting. This is the introduction to the shoulder surgery block pack. I have two disclosures. I'm an advisor for Sonoran Biosciences, and I also write a couple articles for Up to Date. I will not be discussing off-label use of medicines or pharmaceuticals.
Regarding the workshop format, this will be a two-station format with 90 minutes total for the workshop. There will be a 15-minute introduction and housekeeping, 60 minutes of scanning, followed by 15 minutes of review and then discussion. Participants will be divided into 4 groups. Participants will only rotate once, so there will be two 30-minute stations. There will be 2 Group A's, 2 Group B's. Group 1A will rotate with Group 1B. Group 2A will then rotate with Group 2B. Station 1. This is where Group A will start. Will include interscalene brachial plexus block, superior trunk brachial plexus block, subomohyoid anterior suprascapular nerve block, and supraclavicular brachial plexus block. Station 2. This is where Group B will start. Will include clavipectoral fascial plane block, costoclavicular infraclavicular brachial plexus block, axillary nerve block, and superficial cervical plexus. The learning objectives for this block pack include: list regional anesthetic alternatives to an interscalene brachial plexus block for shoulder surgery, identify common sonoanatomy in the posterior cervical triangle, describe local anesthetic dosing and associated complications with performing an interscalene brachial plexus block. So let's get started. Before I take you through sonographic images and start going through the sonoanatomy, I first want to take you on a tour and review the shoulder innervation. As you'll notice in this slide there's multiple different areas of the shoulder that you need to cover, including the cutaneous and sensory, the bone and capsule, the glenohumeral joint, the rotator cuff muscles, and then the muscles of the shoulder. We're essentially talking, as your kind of primary targets for the shoulder, is C5 and C6. And when you look at specifically the actual nerves, the distal nerves that innervate these areas, there's generally 2 large nerves that control a lot of these areas, and that's the axillary and the suprascapular nerve. And I've color highlighted several of these as they're involved in each of these segments. So later we'll specifically talk about blocking these nerves individually.
Expanding on the shoulder neuroanatomy, on the left-hand side you'll see an illustration of the upper extremity. You have several key nerves that innervate the skin around the shoulder, and that's the axillary nerve on the lateral aspect. On top of the shoulder is the supraclavicular nerve, which is coming from the cervical plexus. And posteriorly you'll see the suprascapular nerve. Of note, some patients have pain in the armpit or under the arm after shoulder surgery. That's often coming from the intercostal brachial nerve, which is not blocked during a properly placed interscalene brachial plexus block. The right-hand side is the myotomes. You'll see the deltoid covered by the axillary nerve, and then posteriorly the suprascapular nerve. This is a nice illustration of the innervation regarding the osteotomes. Here you see the supraclavicular nerve and the suprascapular nerve innervating the clavicle, the axillary nerve innervating the proximal aspect of the humerus, with the radial nerve the distal aspect. You have the anterior portion of the scapula, the subscapular nerve, while the posterior portion is covered by the long thoracic and suprascapular nerves.
Moving on from the neuroanatomy of the shoulder, let's discuss first interscalene brachial plexus block and discuss some considerations, the minimally effective volume, and what happens with the phrenic nerve, because this is often the most important discussion regarding whether or not you should be doing an interscalene brachial plexus block, whether or not the patient will tolerate it. 3 important studies that should be highlighted regarding interscalene brachial plexus block and minimally effective volume. The first is our Regional Anesthesia and Pain Medicine 2010 publication titled Minimum effective volume of local anesthetic for shoulder analgesia by ultrasound guided block at root C7 with assessment of pulmonary function. And what they injected was 0.75 ropivacaine, and they found that the minimum effective volume for 50% of patients was 2.9 milliliters, and 95% of patients was 3.6 milliliters. A study in 2011, published in the British Journal of Anesthesia, titled Ultrasound Reduces the Minimum Effective Local Anesthetic Volume Compared with Peripheral Nerve Stimulation for Interscalene Block, found that the minimum effective volume was 0.9 milliliters regarding 0.5% ropivacaine. Now, both those two studies were for analgesia. The last study was for surgical anesthesia, and they found that the minimum effective volume was 5 milliliters regarding surgical anesthesia, and the authors actually stopped it because they didn't think there was any utility below this value. So this begs the question of why reduce the volume? Why risk it? What's the point of using 1 milliliter, or 2 milliliters, or 5 milliliters? Why not just use 10 to 15 on everyone and properly block the brachial plexus and not have problems with patients that you may miss? And this is the reason that it comes up is because when you're using high volumes, you're more likely to block the phrenic nerve, and some patients, they can become very symptomatic and have problems with their breathing. Specifically, a study looking at that looked at 40 patients randomized to either 5 or 20 milliliters of ropivacaine, 0.5%, and they noted that diaphragmatic paralysis using 20 milliliters was essentially 100% of patients. Now they were able to reduce that almost in half by cutting their volume to 5 milliliters. And it should be noted that still 45% of patients, when you used as low as 5 milliliters to block the interscalene brachial plexus, still had diaphragmatic paralysis. So what happens if you block the phrenic nerve? A 1992 paper by Ermi et al., published in Anesthesia and Analgesia, showed that with phrenic nerve blockade, it results in reduction of FVC by 27%, a reduction in FEV1 by 26.4%, and a reduction in peak expiratory flow rate by 15.4%. So there is a significant reduction in the actual mechanics of the lung. And they bring up, this is coming straight from the paper, is the recommendation by the authors is that interscalene brachial plexus block should not be performed in patients who are dependent on an intact diaphragmatic function and in those patients unable to tolerate a 25% reduction in pulmonary function. So in the majority of healthy patients, this will be no big deal. This is a consequence of doing an interscalene brachial plexus block and a common side effect. Some healthy patients do feel a little bit of shortness of breath, but often their SATs are 100%, and you can often coach them through that. The concern is that when the patient's a little bit sicker and they will not tolerate this reduction. So these are the patients that you really want to think about alternative techniques other than an interscalene brachial plexus. So let's take you on a quick tour of the sonoanatomy of the interscalene brachial plexus and the supraclavicular view. So this is a looped video of the posterior cervical triangle, starting at the supraclavicular view and then scanning cephalad up into the interscalene groove. Here you'll see the interscalene groove. I'm going to wait for it to cycle back through once more and start at the beginning. You notice here the subclavian artery. Lateral to that is the brachial plexus. And as you scan up, it forms into C5 and C6 in between the anterior and middle scalene muscles. Again, as it comes through, this is the first rib. This is the drop-off of the lung, subclavian artery. Here's the brachial plexus scanning at cephalad. You'll see it form into C5 and C6. Again, in between the interscalene muscles. When talking about the brachial plexus of C5 and C6. I can't help but talk about the wonderful Carlo Franco paper that specifically looked at the gross anatomy and the correlation between that and the sonoanatomy. And they nicely denoted C5 here as this hypocoic structure and a bifascicular C6. So two hypocoic structures, two circular hypocoic structures denoting C6. A common mistake when people were learning this is they were calling this superior, middle, and inferior trunks, which we know is that to be false. Now, sometimes you can have patients with C5, C6, and C7, but in this scenario, as nicely pointed out in this paper by Dr. Franco, is that you're looking at C5 and the individual fascicles of C6. So two fascicles here are bifascicular C6. So how do you know if you're blocking C5 and C6 or C5, C6, and C7? Well, there's actually a way for you to count or follow the nerve roots as they come out of their foramen. And you know, this is anterior and this is posterior. Here is C5. This is the transverse process of C5, and it has a U shape denoting the anterior process and the posterior process. Similar with C6 that has an anterior and posterior process, a U-shaped. But C7 in particular is missing that anterior structure. It just has the posterior structure. So you can actually count those back. So here you can see the U shape of the nerve coming out of the foramen and C7 missing that structure. To further provide detail in what I'm discussing right now is again anterior and posterior. You'll notice this U-shaped structures. And C6 U-shaped structure, and again C7, it's missing its anterior and only has its posterior. And sonographically how that looks, it's almost like a camel's hump here with the nerve root in between. And you'll see these bony structures in between with acoustic shadowing from the bone. So it kind of looks like a camel's hump. Whereas C7, here's the nerve root, but you really only see the posterior aspect of that. So this is one way that you can actually trace the nerves into the foramen and count them out to know that you're blocking C5, C6, or C7. This is a live example of how you can count the individual nerve roots. Here is C7 and the posterior transverse process. C7 coming in and out of its foramen. Here's C6, bifascicular C6, and then it's monofascicular. There's bifascicular. Now, as you're scanning up, you'll enter its foramen, and you'll see a camel hump bony appearance of the anterior and then the posterior transverse process. And here's C5 as it enters. Again, the anterior and posterior aspect. You'll see that camel hump appearance, and that's how you know it's C5. A slight change to performing a interscalene brachial plexus block is just going a little bit more distal and performing a superior trunk block. And the thought process here is that you're a little bit more distal, and therefore there's potentially less chance of the local anesthetic tracking back and knocking out the phrenic nerve. So there's been several studies on this block, but this is continues to be an alternative to an interscalene brachial plexus block of blocking essentially where C5 and C6 come together and blocking the superior trunk. You notice here that the superior trunk kind of looks more like an oval, and it has multiple fascicles within the actual trunk. So this is what the superior trunk looks like. Again, another alternative to providing very good analgesia to a shoulder surgery instead of a traditional interscalene brachial plexus block. This is a live example of what the superior trunk looks like. Here you have C5 and C6. As you scan more distal, you get into that oval appearance of the superior trunk. Here you'll notice the suprascapular nerve coming off the superior trunk, then coming back as you scan cephalad. Again, that's where the superior trunk is formed. Now you're into roots of C5 and C6. C5 and C6. Another block that we'll be covering is the costoclavicular block. This is a slightly more proximal infraclavicular approach to the brachial plexus. Again, hoping to preserve the phrenic nerve, but still blocking the innervation to the shoulder. This has the probe that's inferior to the clavicle. Here you have the axillary artery, the lateral, medial, and posterior cords. And this is the area that you'd want to block when performing a costoclavicular nerve block. Here is another sonographic video showing the costoclavicular anatomy. Here is the axillary artery, because we're inferior to the clavicle, and the brachial plexus that is just lying just lateral to that in the form of cords, the middle, lateral, and posterior cords. Again, axillary artery, and then the brachial plexus just lateral to that. Moving on to a new approach to blocking the innervation, or some of the primary innervation for shoulder surgery. This is called a suprascapular nerve block. One of the preferred approaches to this is subomohyoid, so this is an anterior approach. As you note that a significant amount of innervation to the shoulder is coming from this nerve, so this is the primary target that you're going after when you're doing an interscalene brachial plexus block. As you can see, the suprascapular nerve coming off of C5 and C6. This is the cadaveric dissection of the brachial plexus, and you'll note here the suprascapular nerve branching off of the upper trunk. Of note, the suprascapular nerve is a large nerve. It's easy to see sonographically, pretty easy target, and noting the anatomy or the neuroanatomy to the shoulder, that this is one of the primary targets of providing analgesia for shoulder surgery. This is how it appears sonographically. This is lateral, and this is the subclavian artery. This is essentially a supraclavicular view, denoting the brachial plexus here lateral to the artery. One of the first nerves that branches off, and very easy to see, is this hypocholic structure here, which is the suprascapular nerve. Notice how superficial this structure is, and the target is pretty easy to block with a couple cc's of local anesthetic. Here's another sonographic video showing what the suprascapular nerve looks like. Here is C5 and C6, the superior trunk. Right there, the first hypocholic structure coming off is the suprascapular nerve, lying underneath the omohyoid muscle. Just lateral to the subclavian artery and the brachial plexus at essentially the division level. In addition to the suprascapular nerve block, some people can also perform an axillary nerve block. Now, mind you, this is an isolated axillary nerve block, not an axillary brachial plexus block. So this is an isolation that you can cover part of the shoulder innervation to help with pain control. You'll see here the probe orientation of the ultrasound, and this is the sonographic image that would correlate with that probe position. Essentially what you're looking for is the posterior humeral circumflex artery, which is a very easy target to see, and you look for the neurostructures that are within that same plane adjacent to the artery. You see the humerus is a very hyperechoic structure, and up here you'll see the humeral head. This is a sonographic video showing the posterior humeral circumflex artery, here pulsating, and then the neural structures that are adjacent to the artery. Just below that is the humerus, and over here is the humeral head. Changing topics slightly, we're going after the clavicle instead of specifically the shoulder. And here is an example of a clavipectoral fascial plane block, specifically for surgeries involving the clavicle, whether you're plating the clavicle or you have a patient with a fracture. So here is the author's example of a caudal to cranial projection of the needle entering the clavipectoral fascia. It should be noted that this will cover the osteotome of the clavicle, but does not cover the dermatome, so you will have to provide an additional supraclavicular nerve block coming from the cervical plexus in order to properly cover this block. Which specifically I'm talking about the supraclavicular nerve as it lies here in the shoulder. So this would be the area over the clavicle that you would need to block with a superficial cervical plexus block. So as you note here in the cervical plexus, they come underneath the sternocleidomastoid and then branch out to their individual distributions. You see the lesser occipital, the transverse cervical, and the supraclavicular nerve. This is a sonographic image of the superficial cervical plexus. Here's the sternocleidomastoid muscle, and this is the area that you would want to place local anesthetic to provide a superficial cervical plexus block. You'll note here that sometimes you can individually see the great auricular nerve and trace it as it moves cephalad to innervate the area around the ear. Now on to a few things that you want to avoid when you're placing needles in the posterior cervical triangle. And this is an excellent example of two nerves that you should know about and be concerned. It's the dorsoscapular nerve and the long thoracic nerve. This was a great paper from 2013. They looked at 50 subjects and whether or not they could see the long thoracic or the dorsoscapular. And specifically in this paper, which is a little bit dated, but still brings home the point, is that around 77% of patients you could see the dorsoscapular and 23% you could see the long thoracic. So again, these are nerves that are lying in the middle scalene. So you want to be able to identify these prior to placing your needle through that muscle. This is another sonographic video demonstrating what we're talking about. So there's C5 and C6, and we're looking at specifically these hyperechoic structures. Here's the hypoechoic center with the hyperechoic structure around it, demonstrating the dorsoscapular nerve. Right there. Here again, scanning cephalad, you'll see those same structures join C6 and C5 up here. Let's now talk about the phrenic nerve. We've talked about why we wouldn't want to block it and the consequence of doing an interscalene brachial plexus block, but let's actually talk about the anatomy and the sonoanatomy. So here, remember C3, 4, and 5. C3, 4, and 5 is the origin of the phrenic nerve. C3, 4, 5 keeps the diaphragm alive. And you'll notice its orientation as it continues to descend distally in its orientation to the brachial plexus. The brachial plexus tends to continue down laterally, whereas the phrenic nerve continues to go straight distally. So there's a larger gap the further and more distal the phrenic nerve and the brachial plexus continue to run versus its more proximal orientation. Here you'll see C5 and C6, and the question that I bring to you is, in this view, can you spot the phrenic nerve? And here you'll see this nice hypoechoic structure superficial to C5, and that represents the phrenic nerve. Now the concern here is that if your approach is out of plane to go after C5 and C6, that there is a chance that you could harm the phrenic nerve and transect it if your needle went right through that structure. So it's another structure that I always like to find prior to doing an interscalene brachial plexus block. Here's another live sonographic video of C6 and C5. Here's the phrenic nerve as you're scanning more distally, running on the anterior scalene muscle, and it's scanning more proximally as it joins C5. Right there, C5 and C6. A couple more structures in the posterior cervical triangle to watch out for. This is a sonographic view of the transverse cervical artery as it lies just superficial to the brachial plexus. Here you'll see it in longitudinal view and a Doppler image showing color flow through the artery. So brachial plexus is here, and this is a superficial structure coming off the thyrocervical trunk. So this is another example of the appearance of arteries in the posterior cervical triangle. We just talked about the transverse cervical artery, and in this image it looks very similar to what the stoplight appearance would typically be, representing C5 and C6. And if you were to actually watch this live, you'd see a very slow heart rate and pulsatility, denoting that C5 is actually hidden, and it represents a transverse cervical artery that is in cross section and not a longitudinal view. So it's something to take some interest in and kind of keep an eye out as you're performing a block in these areas. This is another artery that you need to pay particular attention to in the posterior cervical triangle. Here is the subclavian artery in essentially a supraclavicular view, maybe just a little bit higher than what you would normally see. And C5 and C6, subclavian artery and the dorsoscapular artery that's then branching laterally. So you can often see color flow when you look with Doppler through this area. It's a video showing the dorsoscapular artery as it branches off the subclavian artery. So here's the brachial plexus. Here would be the brachial plexus and the dorsoscapular artery running right through that. We'll play it one more time. Again, subclavian artery, brachial plexus, dorsoscapular running right through. Well, thank you for allowing me to take you through that quick introduction for the block pack for shoulder surgery. There's multiple things that we discussed, specifically things that you're worried about while doing an interscalene brachial plexus block, and then alternatives to performing interscalene brachial plexus block. I hope this workshop is very informative and educational, and I look forward to seeing you all in Las Vegas.